Ethical Leadership in Healthcare and Other Industries, a symphonological grounded theory approach. Dr. Scholastica A. ILoghalu Introduction. The importance of understanding ethical decision-making and developing management policies to promote ethically sound decision-making processes in organizations cannot be overemphasized. An organization's well-being, competitiveness, overall success, and ultimate lifespan largely depend on the commitment of its management and staff to ethical decision-making principles. Choices made when ethical dilemmas arise, especially in gray areas where there are no established laws and regulations, often have a lasting impact on all the stakeholders of an organization. Ethical dilemmas arise when an individual has to make a choice between similar options that have significant moral implications. And as is common with organizational leaders generally, many healthcare executives regularly face ethical dilemmas. In fact, the peculiar nature of the healthcare industry makes leaders of the industry more prone to ethical conflicts. Healthcare professionals face bioethical dilemmas in all facets of the healthcare system, from administration to the bedside. Incidentally, studies have shown that such dilemmas often cause those affected to experience significant moral distress in dealing with organizational leadership. It is no surprise, therefore, that healthcare administrators' ethical dilemmas have been a major concern due to the balance required between business operations and patient care. Patients' rights need protection in managing healthcare. Sadly, this truth is often ignored, especially when there is no principle or formula to apply before making decisions in the healthcare system. Thus, the paramount question is, how can healthcare administrators reconcile business and clinical practices in ethical decision-making? The question is important because it forms the basis for the leadership paradigm needed to improve healthcare services and public policy initiatives. This is why a book like this has become timely and handy for all organizational leaders and professionals. This book was birthed out of the realization that there are not many studies on the ethical decision-making process of executives in healthcare concerning business operations and clinical practices. In actual fact, the field of healthcare is virtually devoid of any model in which researchers have questioned administrators' decision-making processes in relation to ethical dilemmas. Yet, healthcare professionals certainly need a decision-making paradigm to address the different dilemmas they face in a logical, acceptable, and ethical context. It is for this reason that this book examines and projects the symphonological theory approach to resolving ethical dilemmas. The author strongly believes that adopting the symphonological normative framework will serve as an ethical compass for healthcare administrators in their decision-making processes. More importantly, it is expected that the findings and postulations in this book will drastically reduce unethical decisions made by healthcare executives and lay a foundation to ensure healthcare administrators take all relevant considerations into account when resolving and preventing ethical dilemmas. Chapter 1, The Unique Business of Healthcare. Is no mere coincidence that the subject of ethics has, in recent times, become quite paramount in discussing organizational leadership generally and healthcare leadership in particular. We currently live in an era that is unprecedented in technological disruptions and increasing pressures on organizational decision-makers. These pressures come in different forms and with differing intensity. And as Palawal, 2006, and Brimmer, 2007, have clearly observed, they include increasing competition, pressure for profits and return on investment, political corruption, values and morals not considered important by younger generations, the expectancy of fast money and profits, and disregard for social responsibility, honesty, and integrity. Specifically for healthcare professionals and managers, the peculiarities and dynamics of the current millennium, including evolving needs of patients, advances in healthcare technologies, improved lifespan, unstable government policies and regulations, rapidly changing healthcare systems and programs, as well as the move towards a patient-centered care, have certainly heightened the complexities of healthcare delivery. Inevitably, therefore, while healthcare remains a universally valued and ethical leadership in healthcare and other industries immediately self-justifying human activity, it continues to generate many elusive and problematic features which invite critical attention. Gallagher, 1972. Our principal focus here is examining and proffering solution to one of these elusive and problematic areas: how healthcare administrators, and by extension, administrators in other fields, can effectively resolve ethical dilemmas and reconcile the demands required of business operations with the ethics of their core profession. However, before fully delving into this, it is essential to establish some pertinent issues, beginning with a demystification of the business dimension of healthcare, to which we have just alluded. The nexus of business and healthcare. The George Washington University School of Business aptly notes, the cost of hospital care is expected to rise from 0.9% to 2.4% of the budget by 2025, increasing the importance of good business practices and educated professionals in the healthcare industry. While some might consider it antithetical or even anathema to link healthcare with business, there is actually an extricable business dimension to healthcare delivery. Indeed, some ardent observers of the healthcare industry would not mince words in saying that healthcare has become a business, a fact that may make some doctors squirm. Nixon, 2013. Even more important is the fact that this business dimension is increasingly becoming more obvious and more indispensable due to certain current and emerging factors. It is essential that we reiterate this business dimension of healthcare here for 3 reasons. 1, it helps to provide better insights into the trajectory and requirements for effective and efficient healthcare delivery in this 21st century. 2, it helps to highlight the paramount roles of enlightened and experienced healthcare administrators in managing and maximizing the changing dynamics of healthcare delivery. 3, and most importantly, it will help to underscore the necessity of ethical considerations in the decision-making process of healthcare administrators. Lingering doubts in the mind of anyone regarding the intersection of business and healthcare would be easily dispelled with a proper examination of the realities facing healthcare provision in recent times. Findings and experience have continued to show that consumers of healthcare are demanding for better services for less money, while also having more options of healthcare providers to choose from than before. For instance, a recent report from Michigan State University revealed that patients want high-quality care with great service and good health outcomes at a reasonable price. It states, this consumer mindset, coupled with the outcomes-driven incentive plan of the ACA, is driving healthcare economics away from the volume or type of medical service to whether that service results in the desired patient health outcomes. P. 17. In apparent response to such shift in patients' expectations and service evaluation, stakeholders are already coming up with models that ensure that just like any business enterprise, consumers of health pay for value rather than performance. Michael Porter and Elizabeth Teisberg, 2006, argue that many for-performance efforts in healthcare delivery are not about quality results, but are about completing processes which may or may not lead to better results. According to them, the only truly effective way to address value in healthcare is to reward ends or results rather than means, such as process steps. P. 51. Ash and Vlop, 2012, have equally asserted that doctors and hospitals who pay attention to the business they are actually in, defined by the outcomes their customers seek, will leave the doctors and hospitals who don't behind. But consumers' demands aside, the environment of healthcare delivery, especially the regulatory environment and the activities of government, has also further revealed the inevitable business side of healthcare delivery. Stuart Gandolf of Healthcare Success clearly captured this by noting that since the advent of healthcare reforms, top-to-bottom changes have been sweeping and sometimes painful. Hospitals, medical groups, and individual providers have increasingly been dealing with tough business issues, too. Murray, 2013, was even more direct in stressing that the need for business innovation in healthcare has never been so urgent. Citing the example of Europe, she said, cash-strapped governments with aging populations are struggling to meet demand for increasing levels of care without pushing up spending. In response, the drive is for greater efficiency and collaboration between different practitioners and specialists. P4. She added, in the UK, the severe budgetary squeeze on the National Health Service at a time of increasing demand for healthcare means NHS leaders need to do more with less. P5. As Murray, 2013, further notes, the healthcare landscape in the United States is even more demanding for a business-like approach to delivering care. She noted, perhaps the most radical changes are taking place in the U.S. Healthcare in the country, public and private, is now 17.9% of GDP, against 9.3% in the UK, according to data from the World Bank. Sweeping reforms in the U.S. under the Affordable Care Act are reshaping care delivery and health insurance. With costs rising and mergers creating supersized hospital groups, a once fragmented industry is increasingly made up of large networks requiring accomplished leaders. P8. The situation in Canada reflects a similar pattern. According to Robert Siemens, 2016, despite billions invested each year by provincial and federal governments to support hospital-related care, significant fiscal gaps are steadily increasing, requiring revolutionary and sometimes draconian measures to close these gaps and balance the budget. Siemens noted, very instructively, over the last few years, it has become increasingly apparent that in order to continue to deliver healthcare, recognizing this is only one component of enabling good societal health, it needs to be more effectively managed and fiscally prudent. The subsequent focus on the business of healthcare has become intense, with many healthcare organizations exploring and adopting business principles and development. This is something that has been previously foreign to us in Canada. It is also important to understand that there is a business implication to the healthcare industry nomenclature. The Encyclopedia Britannica describes an industry as a group of productive enterprises or organizations that produce or supply goods, services, or sources of income. Similarly, the Corporate Finance Institute, CFI, defines an industry as a group of productive enterprises or organizations that produce or supply goods, services, or sources of income. The healthcare industry shares the above characteristics of any other industry, howbeit in a unique way, since it prioritizes safety of life and promotion of well-being above all other benefits. This makes it obvious that the scope of the healthcare industry goes beyond professional practice and that it cannot be sustained with a mere practice paradigm. Expatiating this, FutureLearn 2020 revealed that the health industry encompasses a wide range of sectors that provide goods and services to treat patients. This includes things such as treating people, preventing illness, and providing rehabilitative medicine and palliative care. As well as those who directly administer healthcare, the industry also includes those who research, manage, and provide essential equipment and services. Some people also expand this definition to include those who provide education, training, and regulation related to healthcare services. P6. Also, Eugene Gallagher, 1972, notes that while the patent mission of the health enterprise is to work for health and against disease, in pursuing this mission, it maintains relationships with the larger society and generates effects which extend beyond health. Viewed as a production process, the health enterprise draws upon resources which, in an economic sense, might alternatively be devoted to other purposes. There is a cost to health production, and the benefits may be weighed against this cost. P2. There is indeed cost to health production. And even though this may seem more obvious in private healthcare facilities or companies, where the owners have to invest substantial capital to sustain product and service supply, as well as get some return on investment, government facilities equally receive a lot of financial support that must be judiciously utilized to derive maximum benefits for the patients and better health indices for the nation. Accordingly, Ash and Volpe, 2012, have insightfully observed that successful doctors, hospitals, and health systems are those who would shift their activities from delivering health services within their walls toward a broader range of approaches that deliver health. This inevitably goes beyond the ambit of professional training and practice in healthcare, as it requires more specialized skills that will help in making better, well-informed decisions that improve the cost and quality of the healthcare provided. Corroborating this perspective, Gandalf, 2020, remarked that a prospective doctor's long and arduous education is often all about medicine, with little training or experience in the business of running a business. He, however, added, No sooner than a newly minted MD hangs out a shingle, but he or she is hit squarely in the face with the reality that healing is an art, medicine is a profession, but healthcare is a business. P1. Administrators of the new healthcare landscape. At the heart of this intrinsic business side of healthcare delivery, as identified above, are healthcare leaders and administrators. These are top-level healthcare professionals who are primarily in charge of budgeting, scheduling, and seeking out ways to improve patient care. Slider, 2020. Also, reducing costs through waste analysis, recruiting competent employees, and retaining talented staff are priorities for healthcare managers. Microsoft System, 2018. In the strictly managerial sense, healthcare administrators are professionals who take charge of the management or oversight of healthcare systems, public health systems, hospitals, entire hospital networks, or other medical facilities. It is such personnel who ensure that individual departments run smoothly, qualified employees are hired, information is disseminated efficiently throughout the organization, specific outcomes are reached, and resources are used efficiently, among many other responsibilities. Healthcare Administration, 2021, P2. According to the Bureau of Labor Statistics, the employment of medical and health services managers is projected to grow 17% from 2014 to 2024, significantly faster than the average for all occupations. However, the successful administrators of the current healthcare landscape are those who are able to astutely complement their professional training with business administration skills. They are business-minded leaders who flip the business model to the customer, giving consumers the healthcare they want by focusing on customer satisfaction rather than the healthcare product. MSU, 2020. Aschen Vlap, 2012, affirm that more than ever, with the changing landscape of healthcare, it is crucial that current healthcare administrators and those of the next generation are forward-thinking and properly educated in both medicine and business administration. The implication is that it has become imperative for healthcare administrators to not only understand the complex structure of the healthcare system and health insurance, but to also employ best practices and maximize profit for their healthcare organizations. In other words, not only should they be knowledgeable about the dynamics of qualitative healthcare delivery, but must be conversant with basic economic principles, as well as possess the necessary skills for motivating, organizing, and rewarding other members of the healthcare team. Essentially, while the healthcare industry needs forward-thinking and agile healthcare experts to forge new paths for it, such also must be business-minded leaders grounded in the best practices of accounting, finance, economics, marketing, management, and strategy for organizational success. Quite commendably, as Nixon 2013 has observed, an increasing number of healthcare professionals have accepted the situation and are seeking business training as they adjust to pressures that they cut costs and improve the quality of healthcare. A George Washington University report also revealed that a large-scale analysis of Harvard Business School's physician graduates indicates substantial growth in the number of physicians pursuing MBA degrees in the last decade. Sawyer, 2018, affirms that medical education has long ignored the business of medicine as part of undergraduate, graduate medical education, but that is starting to change. As if to confirm this, Nixon 2013 said, there are 54 universities that offer dual MD-MBA degrees, up from 39 in 2003, according to Association of MD-MBA Programs, P8. He also quoted Amelia Pear, president of the Allegheny County Medical Society and a McMurray plastic surgeon, as saying, "Doctors are getting business training because there is more equipment, personnel issues, and marketing that is required to run a practice than ever before. And if you are an employed physician at a hospital, you must show value for your continued employment." P9. Ethical concerns. It must be noted, however, that despite the immense transformation being triggered by this increasing awakening to the business dimension of efficient healthcare provision, there are also concerns about the possibility of excessive commercialization and the attendant repercussions on the quality of care, the well-being of patients, and the integrity of the healthcare profession. Sawyer, 2018, describes this as a situation in which healthcare organizes doctors and patients into a system where that relationship can be financially exploited, and as much money extracted as often as possible by hospitals, clinics, health insurers, the pharmaceutical industry, and medical device manufacturers. In recent years, rising healthcare costs have resulted in families cutting back on care and facing financial problems. KFF 2012. According to KFF 2012, more than 50% of U.S. families lost their medical care due to cost concerns. Healthcare executives can note such problems from data that show that most families resorted to using home remedies and over-the-counter medication rather than going to see a doctor, dentist, or other healthcare professional, and avoided signing up for healthcare. KFF 2012. This, among other reasons that we will be considering shortly, further justifies the need to re-examine and reinforce the crucial place of ethics in healthcare administration. Understanding the role of ethics in healthcare administrators' decision-making process through strategies and policies will help to promote ethically sound decision-making in healthcare organizations. It will also invariably assist in decreasing unethical decisions made by healthcare administrators, as well as laying a foundation for ensuring all considerations taken into account are relevant when resolving and preventing ethical dilemmas. A healthcare organization's overall well-being depends on the administrator's ethical decision-making process. Chapter 2: Healthcare Scandals: Imperatives for Ethical Considerations. Healthcare is growing faster than many other sectors of the economy, and expectedly, its share of economic activity has increased over time. For example, as recent studies have shown, whereas transportation, education, agriculture, and other industries grew at a rate that was closer to the economy, healthcare was an exception. According to KFF 2012, the total cost of healthcare spending in 1970 was about $75 billion, or $356 per person. In less than 40 years, these costs grew to $2.6 trillion, or $8,402 per person. The share of economic activity devoted to healthcare increased from 7.2% in 1970 to 17.9% in 2010, KFF 2012. Researchers for the Centers for Medicare and Medicaid Services projected health spending to be nearly 1/5 of gross domestic product by 2020, KFF 2012. In recent research, according to Schrank et al. 2021, the year 2021 is expected to be a busy year for U.S. healthcare policy. There is a pressing need and opportunity for health reform that helps achieve such a goal. The coronavirus disease 2019, COVID-19 pandemic, which placed stress on an already strained system, has only exacerbated many of these shortcomings. Schrank 2021 P1. Rather disturbingly, however, it appears that the rate of scandals generated by unethical decisions taken by healthcare leaders has continued to grow in proportion to the growth of the healthcare industry. Grunstein Amato, 1990, focused on unethical practices among healthcare executives and the tension such acts elicit while at work. The result indicated the issues of concern are multidimensional and range from level of care and budgetary improprieties to lying and personnel-related issues. Accordingly, the 2010 estimation of costs to U.S. taxpayers for fraud and abuse in healthcare was over $11.9 billion a year, with most of the abuse attributed to acute care settings. Rohraf, 2010. Worse still, according to Meyer 2019, investigations over the years have shown that patients continue to die at prestigious hospitals from preventable errors, even after physicians and staff warned hospital leaders about chronic safety issues. Catalog of ethical failures. From findings of past studies and reports, the bulk of unethical decisions taken by healthcare leaders, including those that eventually resulted in damaging scandals, were prompted by the desire to increase or sustain revenues and preserve reputation. For example, in 2019, the New York Times published an expose written by Ellen Gabler that revealed how patients with heart conditions had been dying at higher than expected rates at the North Carolina Children's Hospital. The facility had a higher mortality rate for cardiac surgery than nearly all the 82 hospitals nationwide that publicly report their death rates. Meyer, 29. Cardiologists at the hospital suspected that there was a problem somewhere in the surgical program system involving surgeons, anesthesiologists, intensive care doctors, and support staff, and they were alarmed. So critical was the situation that one of them was quoted as saying, "I ask myself, would I have my children have surgery here?" In the past, I'd always felt like the simple answer was yes for something simple. But now, when I look myself in the mirror and what's gone on the past month, I can't say that. And if I can't say it for my kids, and that should be our group discussion, if we can't all look ourselves in the mirror and think we're doing the right thing, then we need to change what we're doing. Gabler, 2019. The then division chief of pediatric cardiology also expressed concern that the hospital indeed had some inadequacies that could be contributing to the complications being experienced with the surgeries being performed there. He said people are aware. Nobody has their head in the sand, like they're not aware that the lack of cardiac intensivists, and the lack of nurses, and the lack of a carved-out CICU, and the lack of a CIC unit, and the lack of this and the lack of that is not piling up. I mean, our house is in total disarray. This is crazy what we're doing. I should be pissed as anybody, and in fact, maybe more. I've never seen anything like it, quite frankly, and we're going backwards, not forward. Sadly, however, while the physicians were concerned about their ethical obligations to patients and considered referring those needing heart surgery to other places, their administrators were more concerned about loss of revenue, job losses, and investors' loss of confidence in the program. Gabler, 2019. This further confirmed the claim by Dr. Stephen Swenson, former Director of Leadership and Organization Development at Mayo Clinic, that once harm occurs, some leaders aren't interested in hearing about it. They may be thinking, if this got out, what would that do to our news rating, our brand, or our referrals? To my end. But it is not only when harm occurs that healthcare leaders are prone to unethical decisions. There are actual cases when administrators collude with pharmaceutical companies and researchers for diverse parochial reasons. For instance, in a recent report, Robert Pearl, 2018, noted that if the tendency to be enmeshed in questionable dealings were to be limited to a few healthcare professionals, it would have been much easier to handle. Unfortunately, according to him, the problems are endemic and deeply embedded in medical culture. He asserted, when it comes to the questionable ethics of accepting money and perks from drug and device companies, doctors and hospital administrators routinely look the other way. In substantiating his claim, Pearl cited, among several other examples, the case of a director of the Brigham Center of Regenerative Medicine, who, after receiving millions of dollars in grants, manipulated photos and lied about the efficacy of cardiac stem cells used for patients with heart failure. In another blistering report in 2019, Mike Hicksonbaugh revealed that Baylor St. Luke's Medical Center was plagued with problems threatening the health and safety of patients. According to the report, the hospital was a place where some people were given medications not ordered by their doctors, where objects had been mistakenly left in patients after surgery, and where sewage backed up into a kitchen stocked with moldy vegetables. It was also a place where transvaginal ultrasound probes, the type used to examine a fetus during an early pregnancy, were not always disinfected properly before being used in subsequent patients, and where staff members weren't always following protocols needed to prevent air from seeping into the blood of patients receiving dialysis, a potentially fatal complication. pp. 23. The immediate question that would naturally spring to anyone's mind following such a damning discovery is, where were the hospital's administrators in all this? The same report provided the answer, revealing that in virtually every section of the hospital, from infection control to quality assurance, from the kitchen to the executive suite, inspectors found that the administrators did not have adequate processes in place to ensure the staff always followed safety standards and learned from serious mistakes. Hicksonbaugh, 2019. Meyer, 2019, also added that some of the hospital physicians revealed that they told administrators about problems with cases handled by the hospital's transplant surgical director and asked for an external review, without success. Unsurprisingly, as it is with most ethical blunders from health administrators, The initial reactions of the leaders at St. Luke's was attempted cover-up. According to Hicksonbaugh 2019, when the rots at the hospital were first exposed in the media, the administrators were quick to reply that all issues had been corrected, while emphasizing that the said issues did not affect the CAM hospital. They also went as far as taking out a full-page newspaper advertisement, touting the hospital's quality. It was soon after this that government scrutiny of the hospital's operations revealed the highlighted deficiencies and many more. Beyond the United States, it would indeed be misleading to assume that the litany of unethical decisions leading to patients' harm or some other damages are limited to the United States. According to a recent study, several high-profile scandals involving doctors, and by implication the medical profession, have occurred in the UK over recent decades, and these mirror those found in many other health systems. Lenz and van der Waal, 1997, Braithwaite et al., 2015. One of such recent scandals was the case of Stafford Hospital, which made headlines in 2009 due to reported deplorable standards of care. Members of local campaign group Cure the NHS, many of whom had relatives that has died at Stafford Hospital, repeatedly called for a public inquiry into events at the trust and their broader context in the NHS. The Nursing Times of UK reported that an estimated 400 to 200 people could have died unnecessarily at the hospital between 2005 and 2013. In response to this, a public inquiry, headed by Robert Francis QC, sat between November 2010 and December 2011 to investigate how the Mid Staffordshire Foundation Trust, which managed the Stafford Hospital, allowed the cases of gross negligence to happen. According to Sarah Calkin, 2013, the Francis report found, among other disturbing discoveries, that the administrators of the hospital had chosen business considerations above ethical standards. Citing the report's findings, Calkin, 2013, states, "Posts were cut and the wards were reorganized into a money-saving clinical floors system. The skill mix ratio of registered nurse to healthcare assistants ratios dropped as low as 40 to 60 in some areas. Staff and patient concerns were repeatedly ignored by senior management in favor of balancing the books. There was a perception that managers were more focused on the organization attaining foundation trust status than on quality of care." The document stated, the inquiry chairman, Robert Francis QC, concluded that patients were routinely neglected by a trust that was preoccupied with cost-cutting, targets, and processes, and which lost sight of its fundamental responsibility to provide safe care. Also, Mannion, Davies, Powell et al., 2019, citing Vandikerkove and Sahuradu, 2010, note that many professionals, often including healthcare administrators, were aware of the poor care or misconduct by healthcare providers, but for one reason or another did little or nothing about it. They added that even when staff did raise concerns, informally or formally, perhaps even blowing the whistle to outside authorities, they were often either ignored or responded to inappropriately by their host organization and/or other agencies in the system. Ethical leadership in Healthcare E and other industry ES. As with the United States, healthcare administrators in the UK also seem to be at a loss in managing cases of unethical practices in their domains. National staff surveys suggest widespread reticence towards raising concerns about poor or unsafe patient care in the NHS, NHS National Staff Survey, 2015-2016. Some of the administrators also believe that there could be serious backlash or dire consequences if they were to raise concerns about colleagues. MPS, 2012. Away from the UK, in 2008, the nation of India was rocked with the news that a kidney transplant racket had been busted in the city of Gurgaon, in the state of Haryana. It was reported that over a 10-year period, hundreds of poor workers were intimidated at gunpoint or otherwise tricked into donating organs. As many as 600 kidney transplants were performed in a private house that was fitted with high-tech operating equipment. Sadly, when a January 2008 raid by the police brought the illicit business to a close, it was discovered that a minimum of 2 hospitals had been involved in the scheme. Gentleman, 2008, quoting an official source, noted that several private hospitals in Delhi and its suburbs were quietly complicit, as they treated patients recovering from kidney transplants. In 2009, another major health scandal broke out, which IMark 2009 described as one of the most significant patient protection failures in the history of clinical research. This time, it was in France, and it involved Poly-Implant Prothèses, PIP, which had sold breast implants since 1991. Within the period, the company manufactured up to 2 million silicone implants, supplying an estimated total of 400,000 women across the world. In 2009, French surgeons began to report abnormally high rupture rates of the implants. After thorough investigations, it was found that from 2001, administrators of the company had begun using unauthorized industrial-grade silicone for most of their implants, rather than the medical-grade silicone they were supposed to use. The goal, of course, was to save cost of production and increase profit. The business strategy seemed to work, as the expense of manufacturing the implants was reportedly reduced by 90%, but it was at the expense of the users, with the ruptures causing irritation, inflammation, and making toxic substances to escape into the body. Soon, the authorities recommended that women with PIP implants have them removed. Ultimately, according to reports, out of 672 preventative removals registered by the health agency AFS, the implants had burst in 43 instances as of December 2011. Ethical failures by healthcare leaders is also a significant issue in Canada. For instance, citing the Canadian Life and Health Insurance Association, CLHIA, Byrne and Wilcox 2019 disclosed that private insurers paid a total of $36.1 billion in healthcare claims in 2018 for almost 70% of Canadians. Disturbingly, an estimated 2 to 10% of those claims, from $600 million to $3.6 billion, are believed to be fraudulent. It was also reported that, in 2018, the Toronto Transit Commission, TTC, fired more than 200 employees for allegedly conspiring with HealthyFit, a medical equipment provider, to make fraudulent claims for orthotics, braces, and compression socks. HealthyFit owner Adam Smith was eventually sentenced to 2 years in a federal penitentiary and 3 years of probation. Ethical leadership in healthcare and other industries. All these cases further reinforce the need for healthcare leaders to recommit to the prioritization of ethics in their decision-making, as doing otherwise could have far-reaching repercussions. According to Byrne and Wilcox 2019, even perceived errors in judgment, negligence, misstatements, or poor performance by a business owner, executive, associated professional, or staff member can potentially damage a healthcare organization irreparably. It is thus expected that healthcare administrators should take a proactive role in acknowledging the moral dimensions of providing ethical decision-making in a constrained economic environment, and in suggesting how to achieve a balance between cost and quality of care ethically. Harvey, 97. Chapter 3, Ethical Principles and Perspectives. Ethics is a system of standards to stimulate, regulate, and rationalize actions taken in search of important goals. Isaac, 2010. It is a branch of philosophy that deals with right and wrong and good or bad. It does not only address dilemmas, it also deals with the treatment of others, the intentions behind one's actions, and the responsibility one has in relationships. Ethics includes such things as treating patients and colleagues with respect, carrying out the expressed wishes of a competent patient, educating patients to care for themselves when they have the ability but lack knowledge, and other similar situations. Miraz, 2012. The word ethics comes from the Greek word ethos, meaning custom, use, or character. Kidder, 1995, p. 63, as was cited by Isaac, 2010. According to Kidder, 1995, ethics is the science of ideal human character, p. 63, or the science of moral duty, p. 63. The word moral derives from the Latin words mos and moris, which mean manner, custom, habit, way of life, conduct, and refers to what is good, right, or proper. Kidder, 1995. Kidder, 1995, noted, good is described as virtue, integrity, and righteousness, p. 15. Ethics is the study of a good life and a way to bring about happiness. Ethics also entails what is important, individuals' purposes, and what makes a long-term difference in life. Brown, 2010. Lorna Storr noted that ethics involves the individual and the communal aspect of moral concepts, 2004. Railton, 2003, indicated that morality is an entire system of principles and standards, whereas other researchers have explained that ethics includes what achieved the best results through the meanings and requirements of what is good and right. Iruksinen, 2002, Kotka-Verta and Nisonen, 1997. Essentially, ethics involves principles or standards of human conduct that determine goodness in conduct. Conduct can be good on its own, or good because it conformed to a particular moral standard. Kidder, 1995. Any action depicting goodness implied a final value that is desirable and not just a means to an end. An individual who assisted another did so because it is the right thing to do, not because it provided a way to benefit. Isaac, 2010. Normative approach to ethics. The word normative comes from the word norm, which means a standard or a rule. So moral norms are standards or principles with which people are expected to comply. Therefore, normative ethics is the branch of moral philosophy concerned with the criteria of what is morally right or wrong. It involves investigating the questions that arise when considering how an individual ought to act morally. The Encyclopedia of Philosophy explains that normative ethics involves arriving at moral standards that regulate right and wrong conduct. In a sense, it is a search for an ideal litmus test of proper behavior. Normative ethical theories refer to religious or other secular traditions. Storr, 2004. According to the Encyclopaedia Britannica, since normative ethics includes the formulation of moral rules that have direct implications for what human actions, institutions, and ways of life should be like, it is typically contrasted with theoretical ethics, or meta-ethics, which is concerned with the nature rather than the content of ethical theories and moral judgments, and applied ethics, or the application of normative ethics to practical problems. The normative approach to ethics is broadly categorized into two: the teleological approach and the deontological approach. Teleological comes from the Greek word telos, meaning end, goal, or purpose. Thus, the basis of teleological theories is the actions that result from consequences to maximize good while minimizing harm. Lawton, 2010. Teleological ethical theories can also be consequentialist because, as well as being directed towards an ultimate goal or purpose, a teleological theory can also look to achieve the best consequence in any particular situation. Two major theories under teleological ethics are utilitarianism and virtues ethics. The aim of utilitarianism is to minimize any harm by maximizing the good. Utilitarian theory is about maximizing utility, happiness in the world, using the best actions with the fewest consequences. Wallach at 2008, and deals directly with situational elements. Mathieson, 2007. A utilitarian approach to an ethical dilemma results in examining all alternatives for consequences, along with a mental calculation of each alternative cost and benefit for each stakeholder affected. Trevino and Nelson, 2007. The Ten Commandments are a good example of utilitarianism. Wallach et al., 2008. Although the problem with this type of utilitarian ethics is that utilitarian principles indicate what ought to be in terms of purpose and goals, Brady and Hart, 2007, and are not a reason to practice ethically. Utilitarian theory is most often associated with unethical behavior, Groves et al., 2008, but remains the most commonly practiced behavior by organizational leaders in the decision-making process. The virtues approach emphasizes virtues, or moral character, in contrast to the approach that emphasizes duties or rules, deontology, which includes a focus on the qualities of character. While the teleological theories examine an individual's actions or responses based on possible consequences, the deontological theories consist of moral obligations and duties. They focus on the correctness of an individual's action, without concern for possible consequences, e.g., a doctor who has an obligation to care for a patient. The deontological approach is a moral law and duty needed in the business climate, but Mathieson, 2007, noted that when ranking duties against each other, conflicts might occur. Deontologists assess duties and attach moral significance to certain relationships. Isaac, 2010. An example might include a nurse who takes care of a patient, irrespective of the abuse the patient gives to the nurse. The type of obligation is what deontologists refer to as a true duty to a profession. Deontological ethicists described ought as a universal or situational duty or right that individuals have toward each other. ILoghalu et al., 2008. The basic notion of this principle is that it is morally wrong to use others as objects to manipulate for personal gain. Harvey, 1997. Deontology serves as a protector of individual rights and holds ethics as a universal obligation to which everybody must adhere, to maintain reason above feeling and principles above consequences regarding morality as a duty or rule of right and wrong when most goods are not accomplished. Isaac, 2010. The justice approach is part of the deontological theories, and the focus is impartiality and privilege. Also, the civil liberties-based concepts indicate individuals have unbalanced rights. Lawton and Parker, 2010. Integrative approach to ethics. As already indicated, ethics involves principles or standards of human conduct that determine goodness in conduct. Individuals can consider conduct to be good on its own or because it conforms to a particular moral standard. Kidder, 1995. Any action depicting goodness implies a final value that is desirable and not just a means to an end. Ethics refers to a system of standards that serves to stimulate, regulate, and rationalize actions taken in search of important goals. Isaac, 2010. Ethics is the study of the good life and the way to bring about happiness. Ethics also entails what is important, individuals' purposes, and what makes a long-term difference in life. Brown, 2010. The phrase ethical theory comes from Plato, Aristotle, and Kant. O'Neill, 2004. According to Kidder, 1995, ethics is a philosophical reflection on moral beliefs and practices. Morality is the beliefs and practices about good and evil by which individuals guide their behavior. O'Neill, 2004. Whereas ethics is a set of values used to judge behavioral acts and interpret emotions. Kidder, 2004. Ethical philosophers. Ethical philosophers such as Plato, Aristotle, Kant, and Lonergan provided the foundation for evaluating ethical decision-making, and Lonergan's levels of consciousness helped to describe responsible ethical decision-making as a process that includes a series of evaluative operations. Roraff, 2010. Plato, Aristotle, Kant, and Lonergan individually reported various ways of processing information to make an ethical decision. But the fundamental ethical context offered by Lonergan assisted with answering how healthcare administrators reconcile business and clinical practices in ethical dilemma decision-making. Plato, Greek philosopher. Plato, 428 to 347 BC, described ethics as a virtue and type of knowledge that individuals can teach to others, while ignorance as a result of lack of virtue is a vice or evil. Isaac, 2010. Plato viewed good as an element of reality and evil as occurring because of imperfect reality. Isaac, 2010. The human soul consists of three elements: reason, spirit, and appetite. Each element has a specific virtue in a good person and performs a specific role. The virtue of reason is wisdom, the virtue of spirit is courage or capacity to act, and the virtue of appetite is temperance or self-control. Isaac, 2010. Justice as an ultimate virtue refers to the harmonious relationship of all other virtues. A just person has some characteristics of reason, spirit, appetite, and justice. Plato indicated that wisdom picks having good judgment, which means having knowledge to make good judgment, as achieved through knowledge and not ignorance. Plato, who advocated for education, emphasized the importance of acquiring education and believed life experience leads to wisdom. Reasonable people must see things for themselves, and philosophers are the only ones required to know the truth. Plato perceived that good leaders serve subordinates, exercise wisdom, act with courage, exhibit temperance, and act in a way to demonstrate justice. Aristotle, 384 to 322 BC, a Greek philosopher and scientist, had a different philosophy of ethics from Plato. Isaac, 2010. As a philosopher, Aristotle regarded happiness as the primary aim of life and defined it as an activity in accord with the specific nature of humanity. Isaac, 2010. The response elaborated pleasure may accompany such activity, but is not the sole aim of Aristotle's premise. Aristotle believed virtues are good habits, and to attain happiness, a person must develop two kinds of habits. A, those of mental activity that leads to the highest human activity, contemplation, and B, those of practical action and emotion, such as courage. Aristotle also believed moral virtues are habits of action and must be flexible to account for differences in individuals and situations. Isaac, 2010. Begley, 2005, indicated Aristotle looked at particular problems and not universal principles of right and wrong to point at ethical actions. The study of virtue encompasses involuntary and voluntary actions of individuals, thus assigning both honor and punishment to the results. People make choices based on the circumstances surrounding them and do not necessarily want to take such action. Aristotle, who was born virtuous, defined justice as the mean or average potential for virtue, and to realize one's potential, Aristotle indicated an individual must have environmental conditioning and role modeling. Isaac, 2010. According to Begley, 2005, Aristotle believed actions fell into one of three types: A, voluntary or intentional, resulting in praise or blame; B, involuntary, where results are contrary to intent and result in pardon or pity; and C, not voluntary or unintended because of ignorance. Ethics theory pertains to individuals and not organizations, which makes using it difficult when evaluating situations, structures, and institutions. Van Staveren, Aristotle divided the just into the distributive and the certificatory. The distributive is a fair distribution of good and responsibilities to people. The certificatory is correcting the balance for those who have an unequal share. Bernard Lonergan, 1904 to 1984, was a Jesuit philosopher whose definition of ethics involved defining human good. Lonergan's idea remains one of the unsettled achievements in recent times because it is applicable to a vast majority of pressing intellectual, moral, social, political, educational, and religious problems. The four levels of consciousness are experiential or having experience, intellectual or inquiring, which involves investigating and having insight or rationale, questioning one's own understanding and checking for correctness; and existential or rational self-consciousness, in which an individual acts from knowledge gained in the first three levels. Isaac, 2010. Immanuel Kant. Isaac, 2010, described German philosopher Kant as the greatest influential thinker of modern time. Kant described human behavior as the result of circumstance, regardless of a person's intelligence level, and noted that individuals must not judge the morality of an act by consequence, but only by motivation. Isaac, 2010. Having good intentions is ideal, so individuals can act in an appropriate way instead of only when told to act. For moral laws to be universal, they must suit the duty assigned and not necessarily to derive benefits from later. Isaac, 2010. Justice is the aggregate of those conditions under which Kant can conjoin the will of one person with the will of another in accordance with a universal law of freedom. Isaac, 2010. Ethical theories. Moral theory. An individual who has a moral theory displays a set of moral values that link moral views and principles to each other, thus ensuring the same moral idea. Lachman, 2007. The opportunity to define terms in constant ways and relate a set of ideas to one another in a consistent manner is what a theory offers. Lachman, 2007, explained a moral theory in three ways. There is a moral standard, which is a measure of what is right or wrong and should be set apart from laws. Lachman, 2007, LaSala and Jarnison, 2010. The fact that an action is legally permissible does not mean it is morally and ethically allowable. Lachman, 2007. For example, Lachman, 2007, asked that if engineers discovered their organization emits a harmful substance not regulated by the U.S. Environmental Protection Agency, EPA, whether they should reveal this information to the EPA. Although the law allows for the omission of the substance, it may not be ethically permissible to do so. The question of what the engineers should do remains unanswered. The engineers might read some scientific literature that indicates the pollutant causes respiratory problems and may cause other more serious health problems. Lachman, 2007. Just as legality does not imply morality, illegality does not imply immorality. Lachman, 2007. To introduce very small amounts of a chemical into the atmosphere would be illegal and violates EPA standards. Therefore, there might be cases in which it is immoral to do so, and EPA standards might be too strict and fail to balance costs and benefits in a rational way. The engineers should therefore reveal the information to the EPA. Omitting the substance is legally permissible, but it might not be morally permissible to do so, which further ignores the settling of the question of what the engineers should do according to the professional codes. The disagreement continues with theorists, as proponents of utilitarianism do not agree on how to measure utility, deontologists do not agree on which duties to apply, and virtue ethicists do not agree on standard virtues. Wallach, Allen, and Smith, 2008. An agreement to the moral views and principles exist if moral growth occurs following exposure to multiple ethical theories by the broadening of one's mind and the maturity of one's outlook. Wallach et al., 2008. Kant's theory. Kant believed moral agents could take actions to be right only if they see such actions to be universally binding. Freed, 1978. Harvey, 1997. Sherwin, 1992. Moral agents are individuals skilled enough to both formulate and pursue their own purpose, and who are responsible for the actions taken that may fulfill those purposes. Individuals must remove moral agents from other items such as daggers or shovels, which exist solely to fulfill purposes imposed by the moral agents. Kantian ethics prohibits the consideration of particular circumstances of an action, including the feelings of the agent or others affected by the action. Harvey, 1997. Kant was one of the greatest influential thinkers of modern time. Isaac, 2010. Kant expressed that circumstance determines the outcome of human behavior, regardless of the intelligence and morality of an act, though only by motivation. Otherwise, no exists. Isaac, 2010. Good intentions are ideal so an individual can act in an appropriate way instead of only when told to act. And for moral laws to be universal, they must suit the duty assigned and not necessarily be for the benefit to be derived later. Isaac, 2010. Kohlberg's theory of moral reasoning. According to Kohlberg's theory, the assimilation of one's moral judgment evolves with time. Roraff, 2010. Kohlberg's six-stage model consists of 3 levels that increase from a level of self-interest to conforming to norms, equal rights, and respect. Roraff. The final stage was the attainment of true deontological theory based on judgment of duties and rights, as opposed to other systems of judgment. Levitsky, as cited in Roraff, 2010, noted that Kohlberg's theory has served as the basis of most measurements of moral judgment. According to Kohlberg's theory, personal development, the acquisition of knowledge, personal experiences, and the environment as a whole can influence individuals' understanding of personal ability and moral judgment. Roraff, 2010. Torin, 2010, indicated that individuals independently examine and delineate moral values and principles through their conscience rather than by relying on a group's norms. Sharing in decision-making, accepting responsibility for individual consequences, and using any opportunities for joint participation that will empower individuals to improve their levels of moral judgment are characteristics of ethical environments. Torin and Wagner, 2010. McKee, Shrimpton, Haworth, and Bell, 2008, noted that various groups in healthcare should influence each other's decision-making abilities. Adopting different perspectives from others, especially groups, should be part of the decision rather than a discussion by their own potential decision-makers. McKee et al., 2008. The delivered opinion is a clear message that stakeholders in priority-setting decisions incorporated a diversity of expertise and opinion. McKee et al., 2008. Ethical judgments involved in the decision-making were not purely technical, but consisted of special interest groups such as clinicians, who should remain in line with others making the decision-making process important. McKee et al., 2008. A better understanding of the values of the public and health professionals might assist in improving the legitimacy of a qualitative investigation and might expand the available range of options for additional research. McKee et al., 2008. Dimensions of ethical standards. Business ethics. Beginning in the 1970s, financial kickbacks and incentives came under intense moral scrutiny. Beauchamp and Bowie, 1979, Isaac, 2010. As business activity takes place in a larger social framework, business people must reflect on the moral judgments of their critics and engage in ethical practices. Jeffrey and Zalta, 2017. Beauchamp and Bowie, 1979, described teleological and deontological theories as the basis for business ethics, which differs from the philosophy of Lonergan, Isaac, 2010. Ethical theory helps resolve moral problems in business and is not something we are born with. It must be developed, Isaac, 2010, 1. Humans learn as they grow and mature, and there are certain things they had better not do, many of which are in their own self-interest. Humans find that some of what they do affects other person, which is how most people develop their personal sense of ethics and moral values. Isaac, 2010. When understood from a mature focus, the language of economics and business ethics can be highly productive, and if the focus is immature, harmful mentalities can develop that suppress mature moral positions and lead to a take-all-one-can-get mentality. Roraff, 2010. The business community's primary decisive factor for measuring success has become the value to the shareholder as measured in financial markets. Roraff, 2010. The scope of business ethics is changing to incorporate the duty of shareholders, employees, customers, suppliers, the community, the environment, and even future generations into the actions of the organization. Roraff, 2010. Two schools of thought that have developed A, progressivism, which promotes the idea that while business behavior is motivated by self-interest, a broader view of responsibility to social change is necessary, and B, ethical idealism, which promotes the idea that organizational leaders can only justify corporate behavior that directly supports stakeholder interests. 2. Professional ethics. Professional ethics refers to the rules and values adopted by organizational leaders. Jones, 2007. Professional organizations are groups of detached persons, identified as members, who master a specific knowledge and skill needed to perform and accomplish a professional level. Sama and Schoff, 2008. Society and professions have a collective contract in which professional members agree not to promote their own self-interest. Harshman, Gilson, Fisher, and Yeager, 2005. And ethical codes of professional organizations serve as guidelines to that end. Jones, 2007. The practice of professional ethics centers on maintaining the ethical values of the profession to which one belongs and appreciating the principles underlying the code. Welfel, 2005. Sanctioning members who violate the code ensures justice prevails and strengthens member commitment. Stevens, 2008. Strong ethical leaders at the helm of professional organizations promote morals in members and trust in the professional community, which confers legitimacy to the organization. Sama and Schoff, 2008. By establishing a community of strong moral values, members receive a constant reinforcement of norms and values to incorporate into their daily lives. Donaldson, 2008. Professional organizations can exercise moral control over members more than any other actors can. Scott and Davis, 2007. Ethical codes apply to both professional organizations and corporate officials. 3. Personal ethics. Health professionals experience ethical conflict in the workplace when their values clash with their perceptions on how patients are cared for and treated. Gaudin et al., 2011. Recent trends in healthcare have created the potential for high levels of ethical conflict, especially for senior leaders in hospital, as they reconcile business operation and quality care to patients who are key partners in the provision of quality ethical care. Increases in public expectations and expectations for high-quality healthcare by health professionals cause a strain on limited resources. Funding has also become an issue, and technological and pharmacological advances provide new but expensive treatment options, which often lead to questions about the ethics of how, when, and whom these new treatments are for. Gaudin et al., 2011.